Welcome back. My name is Hampton Richards. I'm a private practicing OBGYN, and this next lecture is going to be on progesterones as well as contraception, both, again, pre and post-menopause. And we're going to tie this in a little bit to the estrogen and hormone replacement therapy lecture that we gave. There's a lot of similarity, there's a lot of the same charts, but that's good because some of these need reinforcement. Especially this one, the cholesterol progesterone production chart. Again, as we talked about in the last lecture, if you haven't taken a chance to pause and memorize this, go ahead and do it. You probably have to do it again, to be honest. Mineralocorticoids, glucocorticoids, and the sex steroids. Progesterone's right in the middle of this chart, synthesized from cholesterol. So anyway, take another look, memorize the enzymes, and think about some of these pathways. Progesterone's made in 3 places in women. There's only one naturally occurring progestin, and that is progesterone. It's made in the adrenal cortex in both men and women. In women, it's made in 2 different places, besides the adrenal cortex, of course. In the ovulatory cycle, it's present in the second half of the cycle, made by the corpus luteum. So again, just as a review, we have this idealized 28-day cycle, where for the first 14 days, there's FSH stimulation from the pituitary, which causes a dominant follicle to grow. There's an LH surge, and there's ovulation. That dominant follicle stays there, but it changes names. And instead of making the estrogen that it was making in the first half, it starts putting out progesterone, and we call it the corpus luteum. So, big fancy word for follicle that released an egg. That corpus luteum lasts 2 weeks only. No matter how long a woman's cycle is, whether it's 28 days or 28 weeks, that first period of time is all estrogen. The last 2 weeks are corpus luteum and progesterone, and then it dies. That progesterone is really important for the pregnancy, so when the corpus luteum dies, something else has to take over, and that's the placenta. So if there is a healthy pregnancy, at that point, it'll start making its own progesterone, sustain itself, and the progesterone for the rest of the pregnancy is made by the placenta. Progesterone works very similarly to estrogen in that it crosses the nuclear membrane. It affects intranuclear gene transcription and protein synthesis through RNA. And it affects a number of different places in the body. It establishes that secretory endometrium in the second half of that 28-day cycle. It counteracts the stimulation from estrogen so that endometrial lining stops growing, creates more vascularization, creates more stability, but less stimulation for growth. And then really just getting ready for the pregnancy. It certainly has some anti-inflammatory actions. Our understanding on progesterone here is changing. We talk a lot about how it decreases contractions at the start of pregnancy, but that really is an anti-inflammatory effect in itself. So now we're starting to use it in high-risk pregnancies later on, because we think a lot of preterm labor and rupture of membranes come because of inflammation, if not infection, but just inflammation on its own. We also use it for pelvic pain. Progesterone locally in the uterus can decrease endometriosis pain and adhesion pain. So a lot of anti-inflammatory effects. Progesterone also is a competitive inhibitor of aldosterone at the mineralocorticoid receptor of the kidney. It decreases sodium resorption because of this. I think that's important for your tests, but clinically it isn't something that comes up a lot in my practice. And then progesterone increases core body temperature. So you've heard about women trying to find out naturally when they're ovulating and using specialized thermometers that have half-degree ticks. So right at that LH surge, when the corpus luteum and progesterone take over, there's a rise of about ½ degree, and that can be a sign of ovulation for family planning. So using progesterones in clinical practice. Well, we can use natural progesterones. Things like prometrium are progesterone, and it's usually compounded in something like a nut oil, a lot of times peanut oil. So if we use natural progestins, we always talk with patients about if they have a peanut allergy. But much like estrogens, progesterones are broken down by first-pass hepatic metabolism. So they get sucked up in the liver, broken down, excreted in the bile, taken back through the enterohepatic circulation, and then go out to the target tissue from there. But at that point, they're dramatically weakened. They're much less strong than they were before. So by creating synthetic progesterones, we can decrease that hepatic metabolism and get more progestin out into the peripheral tissue where we want it to work and have it last longer. So with one exception, these are made from 19-nortestosterone. They're derivatives of that. So they almost all have some varying degree of androgenic effect. There's a couple different generations that have been formed. You'll see the first one, norethindrone and norethindrone acetate. This was the first generation. Certainly, as they developed this, they said, we want something that's going to skip that hepatic metabolism. And then they said, well, how can we make it stronger? So we came up with a second generation that would have even a stronger effect. And that's the norgestrel and the levonorgestrel. But the price of making them stronger was an increased androgenic effect as well. So these hormones have theoretically more of those androgen-based problems that we'll talk about in a little bit. So the third generations were designed to have less of an androgenic effect, still be strong, but weaker androgens. That's desogestrel and norgestimate. And then there's even generations beyond that. There's a fourth, and I think they're working on a fifth. And then there's a unique one, drospirenone, which is a 17-alpha spironolactone derivative, which is entirely different. It apparently is supposed to have some anti-androgenic effects. It's supposed to have some anti-mineralocorticoid effects. So at least in theoretic practice, when you talk with the drug reps, it's supposed to be good for water retention, maybe as a diuretic, maybe as a weight loss. It's supposed to be good for women with acne because of that anti-androgenic effect. I want you to know about these categories, and there's certainly been a time when we were very consumed with trying to pick the right progestin for the right woman. I think we're moving to a phase in clinical practice where really we see that most of these work the same way, or at least they work differently in different women, but that's a little bit unpredictable. And we're going to talk about that a little bit more as we get down into our contraceptive discussion. I think in terms of theoretic side effects, all of our progestins are going to have headache, potentially weight gain, depression, libido, or osteoporosis. I think that the more androgenic ones, so that first and second generation, the norethindrone and norethindrone acetate, the norgestrel and levonorgestrel, you're going to theoretically see more acne or hirsutism or more of the bad lipid profile. So increased total cholesterol, increased low density or bad cholesterol, and less of the high density or good cholesterol. So let's talk about contraceptives, and then we'll get into sort of more of what the real clinical experience is with these different progestins. Most oral contraceptives are made from one of the synthetic plant estrogens. Ethinyl estradiol is the big one. I think you'll see that in most of the ones that you're going to use in clinical practice. Again, we're talking about oral contraceptives, manipulated in a way to decrease first-pass hepatic metabolism and get more estrogen out to the peripheral tissues. And then they're combined with a variety of different progestins, any of the ones that we've talked about, as well as around the world. When we think about how contraceptives work, at least the hormonal ones, it's the progestin which makes up the core of it. So just like with hormone replacement therapy, we said, well, estrogen's the big dog. It does all the stuff we want it to do. Progesterones are just there to prevent endometrial cancer or to decrease that stimulation of unopposed estrogen to the uterus. Well, with oral contraceptives or any of our hormonal contraceptives, progesterone or progestins do the lion's share of the work. And they do that by negatively feeding back up to the anterior pituitary and decreasing that gonadotropin stimulation to the ovaries. So it sort of does it enacts our negative feedback, decreases stimulation, and that keeps that dominant follicle from being formed. So you knock out that FSH, the dominant follicle isn't formed, and so you can't ovulate, you can't release an egg. The estrogen does play a part in all of this. I don't want to downplay it too much, not as much as progesterones with hormone replacement therapy. So estrogens mainly work by stopping that LH surge mid-cycle, which is what causes the rupture of the follicle and the release of the egg. But the failure rates when you take estrogen out only go up from like 1 to 8% at its worst. And it might, in many cases, it's even less than that. So the vast majority of that contraceptive power comes from the progestin. It has some other effects too. It works to change the cervical mucus. You know, again, from family planning that a woman can actually tell when she's ovulating because there's a change in the cervical mucus, and that change has a very real effect. It's there to shotgun the sperm up into the uterus and up to the tube where it's going to fertilize the egg. And if you change the characteristics of that cervical mucus and thicken it in a way to become essentially impermeable to the sperm, that's going to keep the sperm from getting there. It also acts on the tube to decrease peristalsis, to decrease that sort of ciliary effect which brings the eggs down to where the sperm is. So the sperm and the egg kind of get frozen miles apart. So no dominant follicle, no sperm and egg getting together. And then if a dominant follicle is formed, if she misses some pills and does break through, that estrogen will stop that LH surge and stop that release of the egg. So what are the other common things that we use oral contraceptives for besides contraception? Well, we talked a little bit about this in the last lecture and going over estrogens as well, but certainly primary hypogonadism. If the ovaries aren't making progesterone and estrogen, a woman needs that for her development of secondary sex characteristics, needs some progesterone to counteract the estrogen that her body and adipose cells are going to make naturally as esterone by peripheral conversion. We can use it for induction of menses. So if a woman, again, talking about this endometrial cancer risk, goes 3 months or 6 months without having a period, that whole time is unopposed estrogen. So we got to give some progesterone in. We could do that just with a progesterone, or we could do it with a combined pill on its own. We usually give 10 or 12 or 14 days and then stop it, and she has a withdrawal bleed or a period. We can use it for ovulation suppression. So even beyond the contraceptive benefits, some women have pain each month when they ovulate, or some women get painful ovarian cysts or hemorrhagic cysts. So if we want to stop those from happening, we can use contraceptive pills, which prevents that egg from forming and that dominant follicle. We can use it to stop cyclic hormonal flow. So that cascade of estrogens and then progesterones and then no hormones when you have your period, that causes a lot of problems. For some women that causes pain. For some women it causes breast tenderness or other premenstrual type symptoms, which can be really debilitating for a lot of women. And certainly endometriosis, even though it's stimulated by estrogen and progesterone, there seems to be something, probably because it is true endometrial lining tissue, it responds to that cyclic flow, that ebb and tide. And when we give those hormones consistently without that up and down, they don't get that big swing and they don't have a lot of that growth or a lot of that pain. There's another effect from giving oral contraceptives, and this is probably a little bit of what obviates all of the theoretic effects of the different progestins, and that's when you have that first pass hepatic metabolism. Even in these synthetic hormones, you do have an upregulation of the liver, of the clotting enzymes, but also of sex hormone binding globulin. So you get more binding globulin out there, which ties up all those natural androgens which are out in the body. And because of that, there's a big anti-androgenic effect with any birth control pill that you use. And this is probably why some of these later generations that are supposed to get rid of the androgenic effects, in clinical practice, you don't really see it as much. And that's because all of them are anti-androgenic because of that increase in the sex hormone binding globulin. So things like hirsutism and acne are helped for most patients with just about any pill. We still shuffle them around for specific patients, but as a good starting point. And then for pain, we talked about this a little bit, but again, pain with ovulation, pain from inflammation, from endometriosis or scarring, you get that anti-inflammatory effect from the progesterone. So how do we give it? Well, we've been talking about pills, and that's an oral ingestion, but you can't keep a pill in your stomach for more than a couple of hours, and then it gets absorbed. So there's different routes that we can use which will increase the amount of time in exposure. And I love these clinically because it takes out the human factor. Compliance, even among the most boring people in the world, with taking a pill every day, even among doctors trying to remember to take a pill every day at the same time every day, is really, really, really bad. And that's why birth control pills, which should have a failure rate of about 0.5%, have a real life failure rate of about 8% because people miss their pills. So we can use a patch, which is estrogen and progesterone, absorbs through the skin, different from a hormone replacement patch, which are all just estrogen in very low doses, but as contraception, they're both. lasts for about a week. It's kind of designed that way because they tend to fall off after about that much time anyway. Women move them around their body each week. You use them for 3 weeks, so each week you take one off and put a new one on, and then the 4th week leave it off, and that simulates that abrupt withdrawal of hormones, and the woman has her period that month. There's also a vaginal ring. This is great because it's once a month. You've seen it on TV, I'm sure. It's a polymer ring. It's flexible. The woman places it herself. There's nothing special about the fact that it's in the vagina. It's not a diaphragm. It's got a big hole in the middle. It's not going to keep the sperm out. But it's just basically another place to have a transmucosal absorption. Stomach can't hold it. Patches fall off after a week. You can leave something in the vagina for a month. 95% of women don't feel it, don't know it's there. True for their sexual partners. Doesn't have any sort of, for the most part, side effects of irritation or discharge or anything like that. And at the end of the month, they, I think classically after 3 weeks, they take it out, leave it out for a week, have their period, then put a new one in the next week. There is the Depo-Provera shot. This is a progesterone-only device. You guys know about this, of course. It's designed to be a 3-month shot. It's a muscular injection. There's no vehicle. You're just injecting progesterone into the muscle and expecting it to slowly leach out because it's in a really thick compound over the course of 3 months. But because there's no real vehicle for it, no structure to control its release, it can be very unpredictable. So because of that, there's a progesterone rod now as well. It used to be called Norplant, but they had trouble getting it in and out, so it was off the market for 5 or 7 years. And for the last 5 years or so, maybe a little less, Implanon has been on the market. A very thin, small cylinder, kind of like a cassette from a pin, but only a couple of inches long, about 4 centimeters long, guided in just under the skin in the arm. And the cartridge or device slowly leaches out progesterone only, no estrogen, over 3 years. And so you get that constant dose of 3 years of progesterone, which stops that follicle from being made, prevents ovulation, and also has those same changes in the cervical mucus as well as the tubal function, which would keep the sperm and the egg from getting together even if she did ovulate, which she's not supposed to do on that device. So those are kind of the different ways that we can give our hormones. We can also cycle them very differently, and that's true both for pills as well as rings or patches. Classically, the hormone birth control pill is designed as 21 days of hormones and 7 days of placebo pill. There's nothing in the classic placebo pills. It's just to help women remember and increase compliance. That way they don't have to keep track of which day they started or stopped or need to take their next one. There's no great reason for a woman to withdraw and have her period. In fact, John Rock is the great scientist who came up with the birth control pill. He's a really staunch Catholic, but really believed he was doing the world a lot of good by coming up with these. Because the number one thing that kills young women, at least until about 75 years ago, or maybe even less, was pregnancy. And it caused lots of problems, lots of death. And if women could control that, he really strongly believed he'd be making the world a better place. But you have to convince the church of that, and you have to convince society of that. So they designed 21 days of hormones, 7 days without, to mimic the normal cycle. So they could bill this to society and institutions as something that was socially acceptable and didn't take women out from the way that God intended them to live their lives. Unfortunately, the Pope didn't buy it, and John Rock never went back to church again, which is kind of a sad story. But that's really the only reason that women traditionally have cycles. There's no medical benefit towards cycling each month because that endometrial lining doesn't really grow when you suppress it with progesterone the whole month. So we can give 21-day packs, or we can give 30-day packs, or we can give 28-day packs, or we can give 1-year packs, or 3-year packs. And they've got that now. We've been doing it for years and years and years, but there's a brand that does a 3-month pack, and there's a brand that does a 1-year pack now. And really that's only kind of marketing and to decrease breakthrough bleeding, because lots of women after 2 months or 3 months or 6 months will start having some spotting every day and really need to have that hormone withdraw, have their period, and then start over again, really more for symptomatic reasons than anything else. With a 21-day pack, there's a bunch of different formulations, or a 28-day pack, I should say. There's monophasic, which is the same hormone all 21 days, and that's what you get when you're using a patch for 3 weeks or a ring for 3 weeks as well. You could do biphasic, where you do 10 days of a progesterone and then increase it for the next 11 days, or triphasic, where you break down 777 and each one increase the progesterone. The theory is that it's going to mimic the natural cycle and the rise in progesterone as the cycle goes on. Again, I think clinically it's more theoretic. At the end of the day, most patients do fine on either one. Now, you're going to find patients who try monophasic and hate it, and you put them on a triphasic and they love it, and that's great. But there's certainly no one delivery system or hormone or phasing which everybody's going to like, or which is a great starter for all of them. I think, at least in my clinical experience and with my partners, that's what we see more and more. So in any case, when you're talking about continuous usage, you can do that with pills. You don't have to use a 3-month pack. You can just throw away the 7 placebo pills and start a new pack. You can do it with rings, where they leave it in the whole month. You can do it with patches, where they don't take that off week. So you can go on and on and on. There's a new pack now that's even a quadrivalent pack. It's got 2 different kinds of estrogen, which is the first time that's been done. And a lot of the packs are putting estrogens in the placebo pills now, which is supposed to stop that withdrawal from hormones, which can cause some of the symptoms. So you get rid of the progesterone, that stimulates the shedding of the endometrial lining, but you still keep a little bit of estrogen. And that helps a lot of women with migraines who get menstrual migraines once a month, as well as a lot of other of the premenstrual symptoms. So you can either just continue them the whole time, or you can use one of those with hormones in the placebo pack. So other advantages of oral contraceptive use, besides not getting pregnant? Well, ovarian cancer risk. Great evidence that your ovarian cancer risk drops 50% if you use pills or any of the other devices, supposedly, not proven yet, but supposedly, for 5 years or more. Endometrial cancer risk. Unopposed estrogen needs progesterone. So women who are anovulatory, who aren't having monthly cycles, having them on a pill gives them that constant progesterone. And then it doesn't matter if they have periods or not, because they're getting the progesterone the whole time. That's the difference between women who aren't having periods on their own and women who aren't having periods because you're giving them progesterone and never having them withdraw. Acne, hyperandrogen, hirsutism, increasing that sex hormone binding globulin in the liver. Can happen with all of them, but certainly more with oral that have that first pass hepatic metabolism. Decreases the LH and testosterone from the sex hormone binding globulin. And then fibrocystic breast changes. Again, this is a cyclic process. Breast pain, which happens because of the change of estrogens and progesterone. So keeping that steady state can prevent that from happening. How do we start oral contraceptive pills, or really any of our hormonal contraception? Well, it can be any time in the first 7 days after their period began. Day 1 is first day of your period. That'll keep coming up in your medical careers. Waiting 8 days or more is a huge risk factor for ovulation. Usually we say a Sunday start. There's 2 good reasons for that. One is it's easy for patients to remember to take the first pill in their pack on a Sunday. The second is that in a 21-day pack, if they withdraw, they generally withdraw a couple days after the last pill, so it ends up being midweek. So they're having their period during the week instead of on the weekend, which most women are happier with. That would be different with a 24-day pack. But remember, if you are going to do a Sunday start, that make sure it's not going to be 8 days since the first day of their period, because they might ovulate. A lot of times we use backup contraception for the first month, meaning condoms. I think if they're using it right, that's not as much of an issue, but remember those compliance issues, especially the first month. And you want to exclude pregnancy before you start every time. If a woman gets pregnant while she's taking her contraceptive pills, we really don't think there's an issue. There's one case control study that shows some urogenital changes, or at least an increased risk. But again, we're talking about one study that's certainly not very well clinically proven. I guess if that comes up on your test, congenital urinary tract anomalies would be the answer. But in clinical practice, we say nothing. We certainly want to stop as soon as we find out that a woman's pregnant. Other disadvantages to oral contraceptive pill use. Well, a lot of this goes along with the estrogen stuff that we talked about before. Myocardial infarction risk, basically women having strokes or heart attacks or other cardiac disease. This is going to be higher in women who smoke. So we say not to use oral contraceptives or estrogen, especially in women over the age of 35. Technically, the studies say 15 cigarettes a day or more, but most people, I think, say if you smoke, you can't use these. It's good impetus for women to stop smoking and kind of prevents that possibility of maybe a little denial in the woman not admitting how much she's smoking a day and getting herself into trouble. Blood pressure is a very real thing. We actually, whenever we start somebody on estrogen for the first time, we'll have her check her blood pressure again. I usually say a week and a month and 3 months afterwards, just at a Walmart or somewhere like that. But they can always come back to the office to do that too. If a woman has controlled hypertension, she can use estrogen, but uncontrolled, no. So that's kind of a fine line, but make sure if you have a woman with very low hypertension that's very well controlled, you don't deny her birth control and have her get pregnant when she doesn't want to, which is going to be a much bigger risk to her health. Triglycerides, there's that counter effect of increasing triglycerides and thromboembolic events like clots, pulmonary embolisms, strokes. Again, this is higher in smokers. A lot of times, like we talked about before, this is in women with baseline coagulopathies that haven't been diagnosed yet. Gallbladder disease is certainly an issue, as is liver disease, which have to do with first-pass hepatic metabolism. And then different hormones or different pill formulations are going to cause different effects that generally kind of fall under the PMS or premenstrual syndrome effects. So women will complain about bloating or headaches or mood changes or breast tenderness. And again, going back and looking at your progesterones, you can try to figure out which ones are going to be the best ones to start them on to avoid some of those symptoms. But a lot of times in clinical practice, it surprises you. And you just have to bounce around between a couple different pills. It's usually worse the first month and goes away after that. So if they can ride it out, it's usually gone. If not by 1, then by 3 months. So certainly if it's mild. And then decreased breast milk production. So estrogen definitely decreases breast milk production in the beginning of the postpartum timing, when they're first trying to learn to breastfeed and first trying to establish that milk production. It doesn't last forever. So I generally, by 6 weeks, will say if they want to start an estrogen pill, that's fine. A lot of my partners wait till they stop breastfeeding. I think either's fine, but certainly not starting an estrogen-based contraceptive right away. So a couple clinical myths. I don't want to miss out on these because we've touched on them a little bit. I think that they're true side effects and contraindications for your test, but they're not really true in clinical practice, and you as physicians need to be very well trained to talk about with your patients. Weight gain's the big one, right? Birth control pills, they make me gain weight. Why would they? Well, progesterone does cause water retention. Progesterone does increase hunger, so we use it for patients with anorexia or chronic wasting because it makes them hungry and makes them eat more. But those doses are much, much, much bigger than what they're getting in hormone replacement therapy or in oral contraceptive pills. There's some studies that show a transient weight gain of 1 pound or 2 that by the end of 6 weeks or certainly by 3 months is gone again. So even if there is a little water retention that happens, over time it dissipates, just like headaches or breast tenderness or any other side effects. I think the big, great study on this are the ones that look at women over time, and they look at women on a birth control pill or not on a birth control, and they come back a year later, and both those groups gain 1.5 pounds. But the women taking a pill blame it on the pill, and the women who aren't don't have anything to blame it on, and that's kind of just true with our patients and human nature. We're all getting older, we're all getting fatter, and we all want something to blame it on. So I think the great studies are going to show you that there's no increased weight gain with birth control pills. Again, with all 3 of these things that I'm going to talk about, there's always exceptions, right? So a patient comes in and says, look, I take the pill, I gain 10 pounds, I get off, I lose it, and I've done that twice, then believe her. I mean, studies can only prove what's true for the majority of people. Everybody's an individual. But on the whole, tell your patients, no weight gain with birth control pills. Also decreased libido, same sort of thing. Woman gets in a relationship, she's very excited about her boyfriend, she starts taking birth control pills, 6 months later, things aren't so exciting and her libido goes down because she's bored with the guy, but you got to blame it on the pill. And that's been done in similar studies too. I mean, it's human nature, our tendencies change, and a lot of times we want something to blame it on. So it can be true for some people, but on the whole, those are not true. Those are not things that you should expect to happen to your patients when you start them on birth control. And then cancer. Birth control pills do not cause breast cancer. They do not cause endometrial cancer. They do not cause ovarian cancer. So these are very safe things to use for these patients. Absolute contraindications to oral contraceptive use, especially, basically we're saying anything with estrogen in it as well. Some of these apply to both estrogen and progesterone. Known pregnancy, we talked about coronary artery disease or stroke or deep venous thrombosis in the past. A liver tumor because of that up-ramping of the liver and that theoretic idea that that would up-ramp that liver tumor as well. Migraines with aura, remember that I hear something or see something every time 2 hours before my migraine hits, that puts that patient at a high risk of having a stroke, period. So giving them estrogen is something we want to avoid because that's going to increase it even higher. Smokers over the age of 35, estrogen receptor positive cancers like endometrial or breast cancer, and then that undiagnosed bleeding because of that endometrial cancer risk. Certainly need to figure out why she's having that before. And then finally, liver disease. That's kind of for two reasons. One is up-ramping the liver might worsen that liver disease. And two is that the liver breaks down these hormones. And so potentially you're going to have really, really high levels, theoretically, of estrogen and progesterone that aren't getting metabolized and just building up higher and higher in the body. So then a couple other myths to think about. One is the antibiotic myth. Rifampin is the only antibiotic which decreases the effectiveness of birth control pills. So you're always going to hear when you're on antibiotics, use backup. Probably a fine thing because if the patient gets pregnant while she's on any of the other antibiotics, she's going to blame you for not telling her when she's one of that 8% of women who get pregnant on birth control pills. So using antibiotics, using backup in that time is fine, but rifampin is the only one that's actually been shown to decrease their effectiveness. All the other ones should be fine. And then the other one is patients who have seizures and take anti-epileptics. That's going to increase their risk slightly as well. Both of these are because of the cytochrome P450 enzyme. Remembering those, trying to think about all the different drugs that are going to affect that. Well, these seizure medications certainly do that as well by inducing different hepatic enzymes. That increases the failure risk. I read one study that said 0.7% to 3.1%. So it's not that you can't use these. When we talk about condoms that have a 16% failure rate, 3% is much better. But these patients need to know that they're going to be at an increased failure risk. And that's true for any of those other drugs on that P450 chart that you guys also need to memorize because it's going to come up in every lecture you ever get. So some people say that if we increase the dose, that might help its effectiveness to one of our 50 microgram pills, which are kind of older pills. But certainly these are patients that might do well with like a progesterone rod or a progesterone only or an IUD or something like that.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
Welcome to Stepping Up with me, Richard Sammons. Woo, woo. Step up, you. Dip, 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 dip. Great job. Now it's time to flex those mind muscles with a lightning fast quiz. Why shouldn't smokers over the age of 35 use oral contraceptives? Need to think? I'll give you a moment. You're right again. Oral contraceptives increase the risk of thromboembolic disease, especially in women over 35 and especially in those who smoke. The only thing smoking in this studio are my sick dance moves.
Hi, I'm Dr. Chris Lewis. It's time for your quick review number 1 for your progestin and contraceptive lecture. Let's get started. If a patient has a peanut allergy, what type of progesterone should they avoid? Well, you want to avoid the natural progesterones. If a patient on progesterone has worsening hirsutism and acne, what generation of progesterone is this patient taking? This is going to be either a first or potentially a second generation progesterone. Name the 3 mechanisms by which progesterone prevents pregnancy. First, there's a negative feedback on the anterior pituitary to decrease gonadotropin release. Next, there's a thickening of cervical mucus, so it acts as a physical barrier so sperm cannot penetrate. And finally, there's decrease of peristalsis of the fallopian tubes. Next, what is the benefit of synthetic progesterones? Well, there's no first-pass liver metabolism. Therefore, you get more drug into the tissues. With the natural progesterones, you get a large percentage of first-pass metabolism, and you get less potent drug into the tissues. Next, how do OCPs exert an anti-androgen effect? Well, OCPs will affect the liver by increasing sex hormone binding globulin. And this will bind to endogenous androgens and decrease their systemic effect. What lab tests should be checked before starting OCPs? Every time you want to start an OCP, you want to make sure these patients are not pregnant. Now, there's not a lot of evidence that you can do a lot of harm with OCPs in a pregnant patient, but you still want to know before starting these medications. What are the contraindications of oral contraceptive use? We're going to go over this about 3 times in this lecture because this is very, very important. First, known pregnancy. Next, coronary artery disease. Next, stroke. Then DVT or deep vein thrombosis. Liver tumors. Migraines with aura. A smoker over the age of 35. Estrogen receptor positive cancer like endometrial or breast cancer. Undiagnosed bleeding. And liver disease. You really need to know all of these because there's a lot of people taking a lot of OCPs and you don't want anything bad to happen to them. So we'll go over this even again later. When should you restart an OCP in breastfeeding mothers? First, you don't want to start any earlier than 6 weeks. There's pretty good evidence that once breast milk comes in and is flowing well, OCPs aren't going to cause a lot of problems. But there are still some clinicians who will wait until the mother stops breastfeeding altogether, especially if they're a frequent breastfeeder, just in the off chance of inhibiting that milk production. Next, cytochrome P450 inducers can increase the failure rate of OCPs. What are the cytochrome P450 inducers? So you'll see this in several lectures in this series. So remember your mnemonic BCG PQRS. So that stands for barbiturates, carbamazepine, griseofulvin, phenytoin, quinidine, rifampin, and St. John's wort. And that ends quick review number 1. Let's get back to your main lecturer.
Progesterone-only formulations. We talked about the mechanism of action. Again, that constant progesterone dose is going to negatively feed back on the anterior pituitary, stop that gonadotropin stimulation to the ovaries, so you're not going to have that dominant follicle form, and then you can't ovulate and you can't get pregnant. Depo-Provera is probably the most, I guess, maybe notorious of these. There is a progesterone-only pill that you can take. It's not quite as effective as the estrogen for that reason we talked about. Remember why estrogen helps? It stops that LH surge, so you get even a better effect. But the progesterone pill is good for people who can't use estrogen. Depo-Provera, again, is that intramuscular injection. It's medroxyprogesterone. Problems with that, we talked about how there's no vehicle, so you can't really control the rate of release. Sometimes it's released really slowly, so it's approved for 3 months, but can last 12 months. And so for a patient who says, I want to get pregnant in 4 months, don't use Depo, because it might be years before, or a year at least, before she ovulates again. It certainly has been tied to osteoporosis, especially with long-term use. We don't really know the long-term implications on that. We try to limit use to just a couple of years because of that. We do show reformation of that bone growth after they stop Depo. So are these women going to be at higher risk of hip fractures later in life? It's going to take more years for us to figure that out. But it's something we're very cautious of already. Depo is the only one that causes weight gain. I told you that birth control pills don't cause weight gain. I lied. Depo does. And I tell that to all my patients, and then none of them want it. but 3 to 5 pounds on average. So it's not slight. And that's probably because it is a big dose. It does cause that water retention and maybe increased hunger, which would be the mechanisms for weight gain. Depression, I think, again, it is a progesterone effect. We're talking about the highest dose progesterone of any of the ones we use. So I am careful in patients with a history of depression, and I caution them about that ahead of time. And then all of our progesterone-only contraceptives can cause irregular spotting. And again, that's because they're working against the estrogen. You're not getting that buildup of the endometrial lining. We kind of visualize it as this bare, exposed endometrial wall with blood vessels that can break easily, and then you have this kind of breakthrough spotting, whereas if you had that thick, healthy endometrial lining, it's much more established and isn't going to break off in that way. So any progesterone only, you're going to have some irregular spotting, hopefully just at the start, and then they acclimate to that, but not always. We talked about that progesterone-only rod that goes just under the skin in the arm, the Implanon rod. Lasts 3 years, is a much lower dose than Depo. So I think in your clinics, gosh, if you remember anything about this, because your clinics are going to come up soon and every one of your clinic patients is going to get Depo, part of that's because you don't know if they're going to come back in 3 months, and that's really, or for 3 months, and that's really valid. Some patients say, look, I just need something I can forget about for 3 months. But don't overuse it because of all these problems that we've talked about. We've got this progesterone rod now, if it can get paid for, but it lasts 3 years. It's really cost effective, and it's a much, much, much lower dose of progesterone. It kind of spikes the first 30 days, but then stays really low, just like the pills. They do get that breakthrough spotting, but they don't get all these other side effects that women get with Depo-Provera. So we think about these drugs in new moms that are breastfeeding, especially in the first 6 weeks. We think about them in smokers over the age of 35, migraines with aura. Clots are a little tricky. Estrogen certainly is the big one that causes blood clots. I work with my hematologist a lot on this because I have a very hard time finding evidence that progesterone's caused clots. And it kind of depends on the hematologist and the clinical situation. So if it's really high risk, most people still shy away. But if it's a lower risk and you can get approval from a hematologist, some of these can still be great. So intrauterine devices, IUDs. This is the best form of birth control out there. It's the most popular birth control around the world. It's the most effective. It's the most cost effective. There was a product called the Dowcron Shield back in the 70s that kind of turned people off and gave us a lot of bad press, but we're building back from that and trying to educate our patients because this really is a great device. There's 2 of them. They're both plastic T-shaped devices. They're small. They're just a couple centimeters in each diameter, and the actual size of the caliber of the device is very, very small. We place these in the uterus retrograde through the cervical opening. So we do a speculum exam, guide these through the cervix to the top of the uterus. The arms spring open and hold it in place so it doesn't fall out. There's 2 strings that come down through the opening of the cervix, but way at the top of the vagina. So the patient can't see them or feel them. They're always worried it's going to be like a tampon string that it's going to bother them. But tell them, no, it's way at the top. You'll never know it's there. Certainly, far more than 95% of patients or their partners never feel them. But I can do a speculum exam at any point and take it out. So one's a 5-year device and one's a 10-year device. But if the patient doesn't like it or she wants to get pregnant sooner, you just take it out. And they're all cost effective after about a year. There's 2 devices. The 5-year is called the Mirena. It's a progesterone coated device. The 10-year is a copper coated device, which is called Paragard. They work by a couple different mechanisms. I think the biggest way to think of how they work is by causing almost an inflammatory reaction inside the uterus, which breaks down that perfect pH balance which is needed for the sperm and the egg to come together. So we talked before about progesterones and thickening the cervical mucus and stopping that peristalsis effect of the tubes to get the ovary and the sperm together. That definitely happens with the Mirena IUD because you get that progesterone effect. But also just having a foreign body in there, whether it's the Mirena or the Paragard, the copper or the progesterone, causes an inflammatory effect. And all those conditions have to be just perfect for that sperm to permeate the wall of the egg and impregnate, and this really throws that off. These are not abortifactants. These do not cause an abortion by stopping implantation every month. You're going to see that on TV. I'm not even going to name the people that say that because it's completely without scientific evidence. In fact, they've even done studies on women getting hysterectomies and done all these flushings of tubes to see if there's pregnancies inside, and there's not. So, not intentional terminations, but looking for failures, and it doesn't happen. These have a lot of great benefits secondarily, especially the Mirena or the progesterone-coated one. That anti-inflammatory effect of that progesterone in the uterus stops pain from periods, it stops endometriosis pain, it stops pain from adhesions and other sorts of pelvic pains. It also thickens the cervical mucus, which keeps infection from coming in. So the main reason that we stopped using these was a fear of pelvic inflammatory disease. If you get gonorrhea or chlamydia on the cervix and you push an IUD through the cervix and into the uterus, you've broken this natural barrier and pushed this ascending infection higher, where it can get out into the tubes and the ovaries and cause scarring and infertility. But the reality is that progesterone thickens the cervical mucus and keeps these infections out. In fact, the whole reason that the Dowcon Shield got such a bad rep was probably because we weren't testing these patients for these diseases before we placed these devices. So we probably were infecting all of these women this whole time. So pelvic inflammatory disease actually decreases, although it is a contraindication. So for your testing purposes, they say high-risk women or women who could have gonorrhea, chlamydia, don't place it. I think that's true. But in clinical practice, you can test a patient, prove she's negative, and place it, and that's actually going to protect her. Also, we talk about ectopic pregnancies. Don't place it in women with a high risk for ectopic pregnancies. There is a relative increase in ectopic pregnancies in women with the IUD. That's different from an absolute increase. So all pregnancies go down with the IUD, both intrauterine as well as extrauterine. But relatively, while ectopic pregnancies might represent a couple percentages of all pregnancies, the drop in that is less than the drop in normal pregnancies. So while it used to be a couple percent ectopic, now it's 50% ectopic, but there's still less overall. So it's an absolute decrease in ectopic, but a relative increase. The message of that is, if you have a patient who gets pregnant while using an IUD, you want to do an ultrasound early and make sure that pregnancy is in the right place. We also, in the past, have said no adolescents, no nulliparous women, or women who haven't had pregnancies yet. Most of this has been disproven using cervical ripening agents and lidocaine. You can place these comfortably in almost anybody, and they're really beneficial for almost anybody. And the failure rate is as low as a tubal ligation, but it's not permanent. So these are great devices. Obviously, you can tell because I won't stop talking about them. I think for the purposes of your test, high-risk people for pelvic inflammatory disease, and then cervical stenosis, just the inability to place it. So we'll talk about those failures real quick. If a woman uses no contraceptive method for a full year, 85% of women will get pregnant. So that's going to kind of be our baseline. And most of the hormonal things that we use, as well as the surgical things in the IUD, are going to drop that to about 0.5%. So if you use these things perfectly, you get down 0.5%. Surgical sterilization, tying a woman's tubes, 0.5% failure rate, give or take. IUD, 0.5% failure rate. The Implanon, progesterone releasing rod, or the Depo shot, about the same, 0.5%, give or take. So real life oral contraceptives should be 0.5%, but they go up to 8% because people forget their pills because of that human factor. That's true to varying degrees with the patch or the ring, although I'd argue less because it's a lot harder to forget the ring, which is once a month, than something that you have to take every day. These are dramatically better than all of our other non-hormonal things. So condoms have a real-world failure rate of 15%. So you take scientists who are real sterile and doing a study and not very passionate, you get a 2% failure rate, which is pretty good, 2% failure rate for condoms. But real life, passionate people, 15%. And that kind of holds true for other things like we talk about the rhythm method or using ovulation timing to avoid certain days. If you get really well-educated people who are really motivated, 3%, but you get real-life people doing that, it's 23% failure rate. And the withdraw method, 4% in real life. Talk about something that's affected by passion, right? 27% in real life. So, oh, and breastfeeding, I'll just mention, should be really low, just a percentage or so, because it stops ovulation, but probably 5% in real life. So breastfeeding is not completely protective. So if it's important to your patient that she's not pregnant, then you really need to fight for her to be on some sort of hormonal device, even if it's a long-term one or something non-hormonal like the IUD. So let's go over the anti-progesterone that we use clinically. This is called mifepristone. It's a little bit infamous. It goes under the trade name RU486, came out of France. It actually competitively blocks the progesterone receptors, which are so important early in pregnancy. So it has a really high use both as an abortifactant, meaning that it causes abortions or causes pregnancy terminations, as well as an emergency contraceptive or sort of a morning after pill. In that case, it doesn't actually cause an abortion when women use it for that. It uses a lot of the same progesterone changes that we talked about before, but it's really effective. It's 99% effective if you use it within a day of having unprotected intercourse. And it's also 99% effective in the first 7 weeks of a pregnancy in terminating the pregnancy. It's safer than surgery. It's really hard to get, so a lot of clinicians, even ones that are pro-choice, don't have it in their offices. So the abortion clinics or the family planning clinics that we have referrals to do. So you have to get it from a doctor. But it's very effective. It's very safe. So it's certainly the preferred method in the first 7 weeks. We give it and then follow it up 48 hours later with PGE1, which is misoprostol, goes under the trade name Cytotec, and that's to give contractions, which usually happen a short period of time after that. But the mifepristone is what actually stops that pregnancy from growing because of the importance of progesterone so early in the pregnancy. Thinking about emergency contraception, again, there's 2 other drugs which are more over-the-counter. The first of these is Plan B, which is a high-dose progesterone. It's 2 doses, 12 hours apart. The sooner you give it, the better. It's approved for 3 days. It actually has some benefit up to 5 and maybe even beyond, but 3 is the word, and sooner is better. Has about a 75% success rate. Doesn't cause an abortion. Actually, there are a lot of those same hormonal things that we've talked about before. It keeps the sperm and the egg from coming together productively. And then there's a new one that just came out, ulipristal, going to go under the trade name Ella. It's approved for up to 5 days, 60% success rate. I'm not sure exactly how that compares to the Plan B at 5 days, but in any case, that's a selective progesterone receptor modulator. I also want to talk real quickly about danazol, which is a medication used for pelvic pain, especially endometriosis. It's a mild androgen. It causes decrease of FSH and LH, again, because of that negative feedback on the anterior pituitary. We don't use it as much because of those androgenic side effects. We've got a lot of other medicines now that work a lot better, but its historical importance, it's got a cool name, so it shows up on a lot of tests. So danazol, pelvic pain, endometriosis, but obviously some of those androgenizing side effects. And then really thinking about that and some of the other things that we've talked about for their teratogen or birth defect causing potential. If you're giving a woman an androgen and she gets pregnant because you're not giving her birth control, then that can affect the sexual development of that baby. And that's true for the GnRH agonists and a lot of the other stronger stuff as well, the progesterone antagonists and any of that. So that's going to wrap up our lecture today. Go ahead and pause your video now, answer the questions, and then when you're ready, turn it back on and we'll review those.
All right, it's time for your quick review number 2. Let's get started. What is the dosing frequency for each of the following contraceptive medications? So first is the hormonal patch contraceptive. You're going to change this weekly for 3 weeks and then leave off for 1 week. Vaginal ring. Leave in for 3 weeks and then remove for 1 week. IM medroxyprogesterone is a 1 injection every 3 months. Progestin implant. The implant is good for 3 years. A copper intrauterine device, or IUD, is good for 10 years. And then the progestin intrauterine device is good for 5 years. Next, what estrogen is used most commonly in OCP? So we've been talking a lot about progestins and progesterone. What is the most common estrogen? That's ethinyl estradiol. Misoprostol serves what purpose after a patient is giving an abortifacient? Well, this is to stimulate uterine contractions. Why is danazol used infrequently to treat pelvic pain? Remember, you can use this for endometriosis pain as well. So, well, danazol is a weak androgen, so the androgenic side effects like hirsutism or acne obviously are not very well appreciated by our female patients. And there's also, if someone is not on birth control, you have to worry about birth defects. So if you're having this androgenic effect on the fetus, it can cause problems with ambiguous genitalia and other problems as well. Next, what are the contraceptive failure rates of the following methods? IUD, 0.5%. Surgical sterilization, or something like a bilateral tubal ligation, 0.5%. Progestin IUD, 0.5%. IM medroxyprogesterone, 0.5%. OCPs, theoretically, they can be the same, 0.5%, but in the real world, it's more like 8%, and that's mainly because of failure to take the medication regularly. Hormonal patch or ring, same scenario, 0.5% theoretically, but with patients not being compliant, it can go all the way up to 8%. Condoms have a 2% failure rate if used precisely well, but with usual failure rates and people not using them correctly, it can go all the way up to 15%. Rhythm method can range between 3 and 23%. Withdrawal method is 4 to 27%. And then breastfeeding is somewhere between 1 and 5%. And that also depends on how frequently someone is breastfeeding. And that's going to end your quick review number 2. Now's a good time to pause the video and complete the in-session quiz. Then restart the video and we'll go through the quiz together.
Jan, are you all right?
Yeah, I just got nauseated all of a sudden.
You don't think you could be, you know.
No. Well, I mean, we've just been trying forever.
Hello there. Don't you just hate waiting until you have time to see a doctor? With the new Doctors on the Go apps, you don't have to. With our home pregnancy test app, you can get an answer right now.
She just pees on the phone?
Of course. Even though the beta HCG doesn't show up in the urine until after implantation, 6 to 12 days after conception, with our app, results are immediate. You can even take it as soon as the morning after.
Oh, I'm too nervous. You read it.
Congratulations. You've won yourself a beautiful bundle of joy.
Really? Thank you so much.
No need to thank me, ma'am. With Doctors on the Go, there's always an app for that.
All right, it's time for your end of session quiz. Let's get started. What are the contraindications to combination oral contraceptive use? Remember, I told you we were to come back to this again. So, number 1, pregnancy. Number 2, coronary artery disease. Number 3, stroke. Number 4, DVT or deep vein thrombosis. Next is liver tumor, migraines with an aura, smokers over the age of 35, estrogen receptor positive cancers like breast or endometrial cancer, undiagnosed bleeding, and liver disease. Really remember these. This is important stuff. What are OCPs containing estrogen not used in breastfeeding women? Well, they can decrease breast milk production. And when can you restart them? Usually after about 6 weeks, but some people still caution and wait until moms are done breastfeeding. What are the side effects of IM medroxyprogesterone? Well, osteoporosis, and that is still under some debate on how bad it can be or if it's permanent. Weight gain, this is one of the few contraceptive means that can cause weight gain. It's usually a myth for the other forms, but for this IM medroxyprogesterone, it actually can cause weight gain. And that might be due to water retention and increased appetite, though we're not 100% sure about that either. Depression, and then irregular bleeding. Which progestins are most likely associated with hirsutism and acne adverse effects? And this is your first and your second generation progestins. Name the hormone that can be administered via the following delivery methods: transdermal patch, norelgestromin, intrauterine device, levonorgestrel, implant is etonogestrel, and vaginal ring is the same, etonogestrel. Next, danazol is a synthetic modified version of which hormone, and what are its associated side effects? Well, it's a synthetic form of testosterone, so it's an androgen, and you'll get what androgens do. They give you hair or hirsutism and acne. And that's the biggest reasons why we don't give danazol to our women very often for pelvic pain. What are the side effects associated with our OCPs? Well, it increases your MI risk, it increases your stroke risk, cardiac disease risk as well. It can give you some mild hypertension. That's why we check our patients' blood pressure usually a week and a month and 3 months after starting OCP. You can get elevated triglycerides, so you want to check your lipid panels. Thromboembolism is really important, and that's why you shouldn't start these medications on people who have a history of DVT or stroke or other thromboembolism. Gallbladder or liver disease. You can also get some bloating and some headache, mood changes, breast tenderness, things that are a little bit like premenstrual syndrome, though this tends to improve over time. And then you can also get decreased breast milk production, though in general if you wait a little bit of time, like 6 weeks, it doesn't tend to be a big problem. What are the contraindications of IUD placement? This is becoming a very, very popular form of contraception, so know who can and cannot take this type of device. So if someone is at a very high risk of gonorrhea or chlamydia, if someone has a high risk of ectopic pregnancy, someone who's high risk for pelvic inflammatory disease, so that kind of goes along with your gonorrhea and chlamydia, and then someone who has cervical stenosis. But most of the time, if you're screening people well for gonorrhea and chlamydia, make sure they don't have a long history of ectopic pregnancies, then most people can take IUDs without problems. What is the mechanism of action of the progestin intrauterine device? Well, it thickens the cervical mucus, you get atrophy of the endometrial wall, and you get this foreign body reaction within the uterus. So you get this inflammatory environment that makes it difficult for the sperm to penetrate to the egg, changes the pH balance, and makes it difficult for fertilization to occur. That's going to end your in-session quiz for progestins and contraceptives. Hope you learned something. Good luck studying.